Good afternoon, friends. My case is simpler than others one, easy to handle. So this 45-year-old male presented with breathlessness on exertion. He was detected to have hypertension with decreased pulse volume in the lower limb, diagnosed to have coarctation of aorta, juxtaductal, and gradient was 50 millimeter of mercury, and associated with severe LV systolic dysfunction, LV ejection fraction 30%, and moderately severe aortic regurgitation. So he was taken up for coarc dilatation. Yeah, it's not running. Can you show the running?
Escape.
Yeah. Okay. So direct stenting with the Advanta V12 stent was done. That up to that there was no problem, and thereafter we thought we check the aortic root to see whether there is any so after stent dilatation there was no gradient across the coarct, zero gradient, almost zero, and then we took him to see whether the aortic regurgitation has decreased or not. Immediately after checking this, what happened? Patient developed right hemiplegia immediately. He's not able to speak. He's not able to understand. Before that, it was all right. So we thought that there must be some clot gone through the pigtail, which was not properly flushed by the nurses, and that led to stroke. So immediately, what we did is the intracranial angiography on the table. Since it is on the table, the procedure which showed that left middle cerebral artery is 100% blocked just after origin. So since it is on the table, we have all the neuro equipments. But that day there was no solitaire. So we tried to cross with the we took envoy guide catheter, and then crossed with the transient wire, dilated with the 1.5 millimeter balloon. Before that, I put altiplase that was available up to 10 milligram through the micro catheters. And this was the final result we achieved. Immediately he is able to understand the thing that he was not able to speak properly, but able to understand. We have to put on ventilator, and in 4 days' time, he's partially recovered. He's not recovered fully. CT showed moderate size infarct in the angular gyrus. So this complication is very rare, but occurred probably clot embolization during aortic root angio to test the degree of AR. Acute stroke on cath lab needs all the hardware to deal with this complication. Large infarct, particularly on the left MCA, is more devastating consequences. So I don't know, patient came walking, and I sent the patient with hemiplegia. So I don't know, I'm not happy. Then search the trials, and all 3 trials published in the this year March showed there is no benefit of intervention, but whatever, this is called MR rescue trial, and then IMS3 trial, and the third one is synthesis expansion trial. So this trial has shown no benefit of intervention than the usual treatment. I think patient has not given me thanks, which is more needed for any intervention. So I don't know, I may be Ironman, but I'm not happy. Thank you.
Thank you very much indeed. We have 2 minutes in case you want questions. Would anybody like to ask?
The only question, I mean, it's just a point of observation that very often when we use pigtails, which are Oxford in nature, they need to be flushed adequately. And this is something we don't do, and we can have devastating consequences.
So how to flush, that is also important. You know, it has multiple holes. So close the holes first, side holes, and then flush distal hole will come out, then close the distal hole, then you have to occlude the multiple holes, open one hole, then you will able to flush it properly. So flushing of pigtail is very difficult. So one has to know how to flush.
Second point is that regardless of all these studies that have come in the March issue of New England Journal of Medicine, which have pointed away from the regular use of acute stroke thrombectomy as with the available hardware in an iatrogenic thromboembolic stroke, I don't see there would ever be a publication against it. This is the way to go. Maybe your dose of RTPA was very high. You probably don't need more than 2 to 3 milligrams of RTPA when you're using. If just by causing a mechanical disruption of the clot, you usually are successful in restoring flow. And that is the way to go. We should not be scared to do it. And we ideally should have hardware, but it is seldom available in all the catheter labs where these are done.
Yeah, no, I agree with that 100%. Those two articles that you showed, that I showed in my presentation, have nothing to do with your case.
Absolutely, absolutely.
Those patients were treated, probably over 5 hours after, the onset of their strokes, or even longer. And this is, clearly an iatrogenic stroke, and I think it would have been remiss of you not to do an angiogram or not to intervene. So that patient's better off, even though they had a bad outcome. They're still better off, and they're probably alive because you intervened.
Tyrone, in our practice, this happens more often when we do balloon mitral valvotomies than when we do, coarctoplasties. So we have to be prepared, and I think every practicing Indian interventional cardiologist at least should be aware that if such a thing happens on the table, after ruling out a bleed, even clinically, one should go ahead and chase that the culprit artery.
I think same thing has happened 2 days before with me while doing the BMV in some peripheral centers, and did the same thing. Patient recovered. So
thank you very much.
Thank you very much indeed.